Welcome everyone to our first Musculoskeletal Insight session of 2026. The topic this evening is rotator cuff. My name's Josh and it's an honour to host the event this evening. To start with, I'd like to acknowledge the traditional custodians of the land that we're meeting upon, the Awabakal people, and pay my respects to elders past, present and emerging who have cared for this land for generations. Like all the sessions we run at RIPN, we hold this core assumption to be true. We believe that everyone participating in this event is intelligent, capable, believes in getting better and is capable of doing that. And so we know there's lots of knowledge and skills in the room, and we encourage you to be critical and to ask questions and be engaged in the event this evening. We'd like to start by thanking our partners, the University of Newcastle and regional health partners, as well as our primary sponsors for the event this evening, Hunter Imaging, the largest provider of diagnostic services in the Valley, as well as Arcane Physio, which is a new online platform evidence-based reference tool for physiotherapists. An update on where RIPN is at the moment. We are continuing to grow. We've just got under 500 members, and this represents over 220 unique workplaces across the Valley. And most importantly, our professional diversity is increasing. We've got more physiotherapists, surgeons, physicians and GPs engaged in our network. And this is important because it requires us to see outside our own lens and work together to solve the complex problems of musculoskeletal healthcare. Some of you haven't been to an event before, so I wanted to let you know about what RIPN is. Our purpose is to bridge the divide between research and clinical practice. We do this through a knowledge translation framework. It starts with finding out what the local problems are. We then identify local leaders, bring those together with an external international expert. We scope the literature, identify what we do know, as well as what we don't know. And what we don't know, and then share that information on an event like tonight. At the end of the evening, we identify local gaps in our practice and then create knowledge through quality assurance projects or formal research projects. We implement the findings of this research and then evaluate it to see if we've made a difference. These events have got quite big, which is exciting, but RIPN's more than just about professional development. It's really about that commitment to drive local practice change. All our events start with a quick pre-event survey, so if you could just jump on this QR code and...
Sorry, I'm just hijacking the mic for a second. This survey is part of my PhD. So for those of you who don't know me, my name's Nikki. I'm the president of the Research in Practice Network. I'm also a PhD candidate, and I'm investigating whether implementing this knowledge translation work that Josh just spoke about in a network like ours, if it can create measurable behaviour change in our community. So it would be great if you could, if you're happy to participate in the research. It involves two parts. There's a survey before the event and a survey after the event. You'll also be contacted at 6 months and 12 months to see if you've implemented any of the changes or if any of the ongoing activities that the network continues to drive, if that's had an impact on you. There's also interviews that accompany that, and that will ask more things around more specific detail that we can't get out in the survey. So there will be some interviews offered this evening. So if you're not in a hurry and you're happy to stick around for 5 minutes and do a quick interview with some of the people involved in the research, straight after the event or at the intermission, you can pop your time down of when you want to do your interview and then stick around at the end for a quick 5-minute chat. That would be awesome. Thanks, guys. Stop that.
Well, move on. The knowledge translation cycle started for this session by interviewing key members across all the disciplines of our network. And there was one theme that continued to emerge in managing patients with rotator cuff related pain, and that was that middle group, the middle-aged patient who comes forward with atraumatic onset of a painful, weak shoulder. The literature defines that as rotator cuff related pain, non-traumatic, non-arthritic rotator cuff pain, which covers a spectrum of subacromial sources of pain, cuff tendinopathy, and partial and full thickness tears at the cuff. And that's what we're talking about tonight. Specifically, we're not talking about the young person who has a traumatic mechanism and a full thickness cuff tear, where surgery provides symptomatic and functional benefit. And we're not talking about the older patient who presents with degenerative cuff arthropathy, where the treatment may be non-operative or operative based on shared decision. Within this group, after the interviews, 150 members of the network replied, and these were the 8 issues that came up as themes of concern. The first one was around tear progression. How long should we hold on to a patient? Is that harmful? What's the cost of that? The second was, what are the principles that govern our non-operative rehabilitation? The evidence that supports an operation or non-operative management. Where does injection therapy fit into the treatment paradigm? How to make sense of the physical exam and marry that up with the imaging findings, particularly when there's a large volume of asymptomatic pathology identified on the MR, and then when to engage the surgeon and which patients should have surgery. Tonight will be broken up into 3 parts. The first part is didactic teaching from each of our experts. We are going to tackle 10 minutes on each of the following: clinical assessment, imaging, rehab, op versus non-op, and surgical decision-making. We're going to have a 15-minute break and everyone gets a chance to reset and refuel, and then we're going to come back and just answer questions and refine what the gaps are locally. To help us through that process, we have our 4 local experts as well as our international expert. The local panel consists of Dr. Ewan Bradbury, sports and exercise medicine physician, Hunter Sports Medicine and Chief Medical Officer of the Newcastle Jets and Newcastle Knights Women's Program, Dr. Laurie Josie, musculoskeletal fellowship trained radiologist at Hunter Imaging Group, Dr. Gajan Selvakumaran, dual fellowship trained orthopaedic surgeon with a subspecialty interest in the upper limb, Dr. Craig Botcher, PhD and APA titled sports physiotherapist, the founder of Regent Street Physiotherapy with 10 years experience as the head physiotherapist for the Australian Olympic swimming team. And it's a pleasure to welcome Josh Zadro. Josh really shares a lot of the key interests we have here at RIPN. One of his primary research questions is how to reduce the use of low value medical care in musculoskeletal medicine. He's currently down at the University of Sydney as a Robinson Fellow and physiotherapist. I did some checking. He's published over 150 papers, contributed at over 100 conferences, and has attracted over $10 million in funding to support his work. So if you would welcome Josh and all our local panel this evening. All right, let's kick off the evening. Ewan is going to tackle clinical assessments and injection therapy. Oh, sorry, mate.
Ewan. Oh my goodness. Interesting. Thank you. Thank you, Josh, for the intro, and to Nikki and Ruben, thanks for having me on my birthday and on match day 3 of the Socceroos. Really, it's my liver probably thanking you more than me. So what we're going to try and do is go through some clinical reasoning framework when using the rotator cuff special tests and understand the role when we use injections. You will is very strong language. I'm hoping we're aiming for slightly less confused tonight. So when you're doing the examination of the rotator cuff, I think the most important thing is that the history should lead you there. I know it sounds really silly, and I know Josh kind of set the scene, but the shoulder examination's got a lot of different bits to it. When we're going to talk about just the rotator cuff, the history should lead you there. We shouldn't be talking about anything like OA, frozen shoulder, and all those normal differentials. We're going to focus on just the rotator cuff tonight. What are we testing for? So obviously you want to know a diagnosis at some point in time, but we also test a lot of the time to see a prognostic, like how people are going to go. Can they do your rehab? Do you need to get anyone else involved? So just think about that when you're doing your tests. It's not just your diagnosis. How useful are the tests? They're not amazing, as you're probably aware, and we'll go into the bits of it why they're not amazing. We're going to quickly talk about what is a positive test as we go through each one, because I think it's really important you know that it's not just pain sometimes, it can be weakness instead. But what I want is probably to state first off is there's, in one systematic review, there's 50 odd tests for rotator cuff. It kind of gives you a hint that none of them are amazing. So what I say to everyone is pick what works for you, make sure that you can do it as it is explained, otherwise it's going to be a bad time for everyone. There's no need to invent the wheel. There's lots out there. The old ones still work. You're better at knowing some and being good at some than knowing a lot and not being very good at any. And beware the shiny new tests. Every new test comes out saying that they have 100% sensitivity and specificity, and then no one can reproduce it. So I'm going to talk you through what I do, which I know is not perfect, but because there's so many, I think it's the easiest way to do it. So for supraspinatus, empty can and full can, I think what's probably important to know with these is what you're looking for. So for these ones, you're looking for pain or weakness. You don't have to have both. You can have one or the other. Empty can and full can both roughly talk about having sensitivities of 80% of sensitivity, and 50% specificity. I think everyone knows how to do those ones. They're pretty stock standard for everyone's not going to go into too much to try and save some time. With infraspinatus, what we do know is that EMG studies show that you really struggle to differentiate testing infra to teres minor on a lot of your tests. So you're probably testing both most of the time. So keep that in mind when you are testing them. Everyone does resisted external rotation. And with resisted external rotation, you're looking for weakness, not necessarily pain with this one. The original description, like I said, with all of them, 100% sensitive, but that hasn't been reproducible. But in saying that, everyone does this test because it does seem to be somewhat clinically relevant. PATS test, or a variation of the hornblowers test. So you get them into 90-90 and you ask them to hold it there and you push the force in the direction of that arrow. This one, they talk about two different types of positives. So if it's just pain but they can resist, you're talking more tendinopathy. But if they can't resist, that's when we're talking more, is it a tear? Once again, their quoted sensitivities is sensitivity of 70%, specificity of 90%. Hard to reproduce once again. Subscap, I think, is probably one of the more interesting ones because the two tests people get quite confused with sometimes. So I do lift off, and I think what is important to know with lift off is that you aren't resisting them. You're asking them to lift their hand off. It's not very sensitive and it's kind of specific, but you normally would combine it. And I combine it with belly press or belly off. Now, with this one, most people do a variation where they actually get the patient to hold their hand on the stomach and pull. The original description is your hand is underneath theirs and you're pushing them out. Does it make any difference? I don't know. But when you're talking about tests that aren't overly accurate to start with, I think it's probably best that we do them how they're first described. Impingement and rotator cuff pain, you can kind of group these tests together. So NIRS, you're doing passive forward flexion and you're giving them scapular stabilization and you want pain at about 120 degrees. And then Hawkins, you're at 90 degrees forward flexion and then internal rotation across. If you combine them for rotator cuff pathology, we're talking about 80% sensitivity and 55% specificity. We're flowing through that, I know, but it was on purpose. So the next part of mine was corticosteroid injections. So the GRASP trial that I'm sure a fair few of you come across is one of the big ones. And I think it's also probably the most relevant to what we do in clinical practice. A lot of the times when you see a lot of the injection trials, it's injection versus rehab or injection versus placebo. But a lot of times you're putting them together. You're not actually ever just doing one or the other. And this does it quite well. The endpoint that they looked at was 12 months later. And the headline is that no matter if you did education, whether you did rehab, whether you did an injection, whether you did a placebo injection, you all got better at 12 months' time. Okay? So basically, why do we do anything? I think you've got to go into papers, and this is what I like and don't like about research. And if you ask Nikki, I don't like research a lot. Read into what the actual endpoints are and read into what this endpoint is. So the difference here with corticosteroids is that, yep, at 12 months, no difference, but at 8 weeks, it was statistically significantly different from everything else in that their pain, their function, all the markers that they were looking at were better at 8 weeks. We don't need to keep patients in pain, so, let's do it. But we kind of already knew this. This isn't new. These papers have been around for ages. They just pick different time points. That's why it's really important to look at research. What's their endpoint? So these ones, 8 weeks. We knew that 8 week range is where corticosteroids really look like they work the best. Whether or not long-term, they do. And that's the risk. We talk about corticosteroids. The big risk that we talk about is the catabolic nature that it can be to the tendon. These two papers, I think, are probably the better two in kind of describing that. The first one's rotator cuff specific. The second one's tendons in general. So the rotator cuff specific one talked about that you had tendon degradation that lasted out to 3 weeks post-injection, and it got worse the more you did and the more often you did them. So it's just dose response related, and it kind of makes sense. The second one on tendons in general talked about that harm lasting out to 12 months. And so I think we've got to consider if we're doing the injection, what is the endpoint for the person as well. So don't just kind of read and go, it's bad or it's going to work at 8 weeks. PRP is a minefield, and I think anyone that's looked into PRP research knows it is, anyone can say whatever they want to say if they ask the question the right way. This study is probably one of the better done ones, and it basically went PRP versus corticosteroids in an RCT, and it showed that at 3 months, which I think once again really important to see what your timelines are, 3 months that PRP showed benefit in pain and function compared to corticosteroids, but at 12 months, once again, they were the same. The reality of PRP is we don't really know a lot about it still. People are going to tell you big claims. We don't know how it really helps attendance. Some people say it's regenerative. I think some of that's probably been disproven in other ways. I think most of the time we think it probably has some anti-inflammatory effect, whether that is by making your body's anti-inflammatory effect work, we still don't really know. How many should you do? Once again, different studies say different things. So sometimes 1, sometimes up to 3. It's not all created equal, and I think that's probably where PRP is moving into, is that it's not homogenous across the studies. So you can get PRP done in multiple different tubes, in multiple different spins. What the people are saying these days is that there's a big push towards the higher the platelet count, the better the PRP. But when PRP first came out, it was like the new stem cells that was going to heal everything. So I think we need to wait and actually see if the research plays out that way. But why you would do it is that it's pretty close to medically risk-free. So besides a needle risk, it's your own stuff. You haven't got the catabolic risk to tendons. So if someone just wants something and they don't want surgery, look, you counsel them that it might not work, but they still a lot of times go for it. I just bring this one up because this is my view on research as much as anything. Anyone that's been to a College of Sports Physicians conference or anyone that's come across John Orchard knows that in any good discussion, he frequently gets the last word. He is one of the smartest people and also one of the most quirky physicians you'll ever come across. And he did this narrative review, which basically went through different papers where they compared PRP to cortisone to placebo. And it basically showed that PRP is better than cortisone, cortisone is better than placebo, but PRP is not better than placebo. And I think that says a lot about how you can write your research, in that you can basically, if you frame your question, you can find the answer you want to find. So what I just say with that is, with the injections in particular, it's the area that we know the best. I think just get good at looking at the research yourself and analysing it yourself and thinking about what you want to find out of it as much as anything. So from all that, very quickly, with the examination stuff, know why you're examining. Diagnosis is only a small part of the picture. It's what we hear about tonight, I get that. But it's also about the bigger person as well. Like, what are we trying to do? What are we trying to treat? Pick your tests and get good at them. There's no point knowing a lot of them. And then if you're going to go to an injection, think why. Is it short-term? Is it medium-term pain relief? We know that they probably are going to work best if you combine it with the stuff that you're all very good at with your rehab, and just know what the limitations are and what the risks are with them. Cool.
And we're just going to have time for questions in the panel. So, Laurie, would you be kind enough to come and talk about imaging considerations?
Great. Thank you. Everyone can hear me okay? That's great. I've just been asked to give a few tips on the imaging components of the shoulder, the middle-aged patient with the undifferentiated pain, potentially rotator cuff pathology. I've gone through the papers and the literature, and as Ewan says, like, you can kind of pull out whatever you want from the papers to support your thoughts, particularly in imaging because it's so subjective. The pretest probability is really, really important for the research that you're doing, and it's hard to get such a broad spectrum of patients for this cohort that we're discussing. So what I did is I used that data just to augment my own anecdotal experience, but that experience is backed up by the data if you want to go and find it to support that. Just the key points to reiterate is that, the imaging of the rotator cuff pathology is what we're looking at. It's not the older patient. It's not the younger traumatic patient. We want to look and consider the utility of the imaging modalities, and I'm going to just sort of remind you all of, there's really only 3. You're all experienced clinicians. I don't want to sort of change how you image your shoulders too much, but just to give you my own experience and thoughts on it so you can consider that in how you prep your patients. And, as here, which imaging distinguishes the findings which may change the treatment pathway. And that's a fairly definitive answer for that one. The key thing is X-ray. I think through all of our careers, be it a cost issue, an access issue, whatever reasoning you want to come up with, X-ray is always provided as that's what we've got to start with, right? I myself sort of just still mull that over in my mind when I'm asked a question. I go, oh, X-ray, no, we don't need to do that just yet. We'll go back to the X-ray if we need to. So I think that's the one thing I want you to take away from this today. In that middle-aged patient population, I'm not saying don't do the X-ray. I'm saying, look, let's just look at the pathology we want to find. Look at the pathology we want to be confirming, and we'll go back to the X-ray if we need it. And why is that? That's the data on the screen. You're not going to see much on the X-ray. And if you reflect upon those patients that you've been imaging, remember, these are not the older patients, not the younger patients. These are those middle-aged patients. You very rarely see anything on those X-rays that really help you change anything. You look at it and you go, great, no arthritis. You could have said that 95 times, 100 times, and only got it wrong of the 5 for all of your patients. Leading on from that, I'm not saying don't do the X-ray. The X-ray is a part of it. But I just don't think it's required as a first step. I think we should move away from thinking of X-ray as a first step in these patients, but it's part of the process. Then the next question is ultrasound versus MRI. It always comes back to cost as part of that process. It's absolutely true that ultrasound is easy, it's accessible, it's well rebated. Even if you pay out of pocket, it's affordable. In some instances, the cost can be similar to MRI out of pocket because the MRI machines are simply far more expensive technology and it takes a lot more staff, a lot more servicing to maintain and keep those running. But the data and the research says that MRI is ultimately slightly better than for partial thickness tears, but they really are the same for full thickness tears. And that's if you need to make that diagnosis. Keeping in mind, if you're clinically confident that you have a full thickness tear, then why do we really need to make that step to an ultrasound? Why don't we make the step to the MR? Because we're already planning for something else in this patient. We're planning for theatre. You're very confident in the diagnosis. There's weakness. There's a history that suits your diagnostic algorithm, as Ewan's hinted at. Why don't we come back to the ultrasound if we need it? So why don't we move to the MRI? We can get the full thickness tear, but we can also get other components of the injury that the MRI will clarify. So when we talk about cost, again, this is what I mean by being a nuanced argument, is that the frank upfront cost, the scan is X dollars, fine. Ultrasound is X. MRI is X. This is more expensive. That's cheaper. This has got to be better. But I think when you look at the diagnostic cost per unit of information, so if you get a spread of the information that you get out of MRI, each one of those pieces of information are far more cheaper per unit than what they are for the ultrasound. As an example, the ultrasound, you might get 5 pieces of really critical information from it, maybe 4. In MRI, you'll get 10 to 15. Divide 10 to 15 into that cost. That's that per unit of information cost. I think that's where MRI really excels in terms of the cost issue. But again, just as per the data, it's a research night. They're equal for full thickness tears. If you want to diagnose a full thickness tear, and that's all you want to get with minimal extra information, go to the ultrasound. When you make that decision to do the ultrasound or the MRI, then you can think about whether I want to be doing an X-ray. I think it's reasonable if you're doing an ultrasound only, you should always include the X-ray. Why is that? Because you've already made the decision to image. There's something about this patient that you want to know more about. If you want to know more about this tear, partial, full thickness, that's fine, do the ultrasound. But whilst you're getting that information, you want to know about the bones. You want to make sure there is no hydroxyapatite or calcific tendinosis, other mitigating things that might pop up and alter how you're going to treat the patient or refer them on. So the X-ray with the ultrasound, I think, is reasonable. Again, not always. The X-ray doesn't have to be done. You can do the ultrasound. You can confirm what you think, confirm the test that you've applied as per Ewan's discussed. Then you can think, well, this is fine. I can stop here. Or you might think, well, actually, no, there's something more in this, and I think the X-ray might be helpful now. Then you might do the X-ray or the MR. Some scan tips. Nikki wanted me to give some examples on scan tips. I'm going to get Gage to swap this over in a minute for me. But I think the most useful things over my years of experience are it's great to have nice people to work with. because everyone's trying to come out with the same outcome with the patient. They're trying to get the patient somewhere, get an answer, get an outcome. And it's nice if people are on the same wavelength. So pick whatever team you like to work with, pick a service based on accuracy, based on access down the corner. I think because imaging is still really, really subjective, you want to be able to get addendums easily. Everyone makes errors, everyone makes oversights. You guys tend to fix your oversights through the next clinical consult. You go, oh, actually, I think I got that wrong at last consult. I'll just readdress this and now we're back on the right track. Imaging, ultimately, the way we work, we just sort of get one shot at the picture. It's like, that's all I think, see you later, that's it. So if in review you think there's something overlooked or missed, you want to be able to get those addendums. It just documents and helps things keep moving in the right direction for everyone. It's a good idea. Ultrasound images, don't waste too much time trying to interpret them because the pictures that are taken are just reflecting the conclusions that we made. So we're just showing you what we want to show you. It's like, oh, it's kind of really dark and I think it's a tear clip. You're going to see something that's really dark and it looks like a tear. That's what you're going to see. So you can't really reinterpret the ultrasound. However, there is the concept of CINI, the real-time acquisitions. They can be really helpful in some instances, but that's more of a nuanced talk beyond the scope of this. And ultimately, if you learn to look at the MRI, there's a few basic things which we'll go through, which can really, really help. And there's a great example here, which is this this example here, which I found, I was just thinking, I've got to find some pictures for the talk, but I do a lot of imaging of joints. And this popped up, and I thought, this is great. It's what the ultrasound was done like the day before. And if you see, I'm just going to try and show you how well it matches. These little bits of bone here matches the little bits of bone on the ultrasound, the footprint of the supraspinatus. And like the ultrasound's fine, like it's doing its job, it's a great image. But the issue, it's not about ultrasound versus MRI. It's just the reason ultrasound and MRI exist as different things in the imaging world is because they're different. That's why they augment each other for different components of different parts of the body. And we can see here, I'll take you through this, is that this is the MRI on the same patient because the ultrasound was done. The ultrasound just showed the bursitis, which I think, that's something that's really, really common on ultrasound and probably overcalled a little bit too much. But I'd say maybe physiologic fluid, whether it was relevant or not, who knows. But that was the diagnosis on the scan. The rest was normal, right? So then the MRI was done, didn't quite match. The scan was done because the patient had symptoms of adhesive capsulitis, not bursitis. So I was like, yeah, it's not bursitis, it's something else. Like I think it's a capsulitis, and that was sort of found on the MR, which was great. But the MR also just showed some chondral thinning. It's more obvious on other parts of the scan. I just sort of just point that out. And also the intrasubstance tear. Whether or not these are relevant or not, that's a different question because the scan was done for the adhesive capsulitis. But again, it comes down to that cost per unit of information that the MR can give you. What I'll do now is Gage is going to get up a scan for me, and Gage's scan, Gage's shoulder. Yeah. What I'll do is I'll just tell you like the easiest way to really interpret an MR in terms of the cuff. Again, we're focusing on the cuff, not adhesive capsulitis or the other stuff, but essentially it's really, really simple. Everything in MRI it's a water map. So you bring up the scan, you just bring up the darkest scan you can find. It's dark. The reason it's dark is because we're getting rid of as much water as we can that's not pathology, which is the fat, the marrow, the protons, everywhere that's not related to some sort of tear or injury. Except that's the nuance, that's the training, is that sometimes normal things can look like pathology. And that's where you'll see those reports where you'll see these huge long lists of it's like, wow, just what do I do with that? That's a long list of stuff. That's because the radiologist is being really, really particular. That's great. But what they're doing is they're listing every single bit of water they can find. And they're either hedging it too much into pathology or not pulling it back enough. So, I'm guilty of pulling too much out of the pathology. I think, well, that's more normal than not. I see so many scans, so I'm often pulling things out of the abnormal back into the normal. And to interpret these, if we think of a tendon, there's very few protons in a tendon. It's, so this works. Yep. There's very few protons in a tendon here. This is the tendon of the supraspinatus, the most common tendon. The subscap, the supra, the infra, the teres, all of the tendons have roughly the same structure. which is the muscle unit, the myotendinous unit, the tendon, then there's the enthesis. The enthesis is really important. Another segue is that the enthesis always gets called calcific tendinopathy in ultrasound. It's really, really common. I think what's almost always happening all the time is the sonographers are overcalling the enthesophytes. So enthesophytes are, a natural part of aging, I think, arguable, a natural part of aging between the tendon-bone interface, the cartilage, the calcification, and that occurs just here. One of the nice things about MRI is you don't see the enthesophytes. So you're not going to be overcalling enthesophytes as calcific tendinosis very often. We're looking at low signal tendon. We're looking at linear architecture. And all we want to see in here is a bright bit of fluid. If I can bring this up, that's that bright bit of fluid that we're looking for. So this is the linear architecture that we're looking for in the tendon. This is normal water. The circle here is highlighting thin, the cartilage here. Nice normal thick cartilage, laminar architecture again of the cartilage layers. And here those layers are lost and thinned because of a bit of superior wear. And then coming back, hopefully, nope. Control, Windows tab. Yep, that one. And then coming back here again, imagining that little bit of water that I pointed out here, which was in the partial thickness or intracellular tear, linear architecture, and then back, most importantly, to the muscle belly here, which is what leads on to what Gadget is going to be talking about in the next slide here, which I'll just about finish on, is this is the real benefit of MR, is in these middle-aged patients is if they really do have a full thickness tear, they're a young footballer, they've ignored the injury, how far that atrophy has progressed. Ultrasound can really struggle to get that to get that assessed to an extent of enough detail for clinical decision making and reliably. And the other thing is the chondral injuries that we often pop up with. So this is an example of nice linear architecture of the tendon. It is higher signal here. That's artifact. Again, it's one of the catches of the MR because it just is. It's a known artifact across that angle point. It's not fluid signal. The tendon's pretty good, but we have the cartilage lifting off here and the fluid undermining the cartilage and chondral fragments in the recess. Ultrasound would never see this injury, just wouldn't see it. And so in summary, a busy slide, you might want to take a picture of it or consider it, but the summary really is, whilst ultrasound is cheap, whilst it's accessible, there's no doubt about that, it will get you the diagnosis of a full thickness tear, hands down. The per unit cost of information is probably far greater. You're getting 4 to 5 pieces of information from an ultrasound, from the MR getting far, far more pieces of information. So I think MRI is definitely the more value test. Ultrasound's the cheaper test. That's your choice, which one you want to use. Ultrasound essentially is for full thickness and deep partial tears. It doesn't tend to see scuffing. Sometimes it can confuse undersurface and bursal surface. Generally always MRI if it's a clinical picture that's complex, surgical consultation. Ultrasound results are misleading. Like the ultrasound example I showed you was a bursitis diagnosis. It was misleading, didn't match the clinical picture, went to the MR, the adhesive capsulitis was supportive. You can assess the atrophy or the cartilage. And again, this comes back, this is just to reiterate this point, maybe we step away from, and this is in the middle-aged patient population, there's no systemic illness, there's no non-malignancy, there's no trauma, there's no reason for risk factors for arthritis, is that proceeding directly to your MR at around $300, it really does avoid the sequential costs. If traditionally we step onto the X-ray, then the ultrasound, then the MR, plus the consults in between these, you're looking at $600 to $700 to get this full diagnostic workup. So maybe just as a finishing note, we can revert to X-ray and ultrasound as being the additional tests if needed, rather than a reflex do the X-ray. It's just something for you guys to consider in your practice workflows. Okay, thank you. Thanks. Thank you. Thanks. Yeah, thanks. Thanks. Thank you. I'll see how I go. Thank you. Thanks, Craig. Yeah, that's it. Thank you.
Thanks, guys. Thanks for having me this evening, Nikki. I'll start off by just acknowledging my workmate of almost 30 years, Andrew Delbridge, who helped me, was a great sounding board to put my talk together tonight. Put your hands up if you're under 30 years of age. Yeah, good on you. Making me feel older than I already feel. Great thanks to Andrew for that. My job tonight is to, don't know what's happened there. My job tonight is to talk about how we as physiotherapists, we're primary physios here, how we're going to rehab this group of people. So middle-aged, atraumatic, rotator cuff related shoulder pain. First of all, I'm going to speak to you about what the research has to tell about the conservative treatments that we can offer, and then how that's going to reflect in our best evidence practice in the clinic. Hopefully this all works. Good. So historically, physio has encompassed a whole host of things. So lots of modalities, different treatments and what have you. And over time, we've realised what is low value care or at worst case doesn't work, and that has been identified. So I'm going to cut to the chase to say to you what has evidence is exercise and education. And that's what I'm going to be focusing on tonight. I'm going to say at the moment that I will be throwing up a few references along the line as I've done here, which will support the comments that I make, but there's a lot of it I'm not going to go into in the interest of time. It's there for you to refer to if you're interested. Okay, so we're going to talk about exercise first. Does it work? So there's a whole host of studies. We're going to talk about just a couple as an example. So Jean Favre in 2018 did a systematic review looking at exercise therapy for full thickness rotator cuff tears. So on the more extreme end of the people that we're talking about tonight. 35 studies, 9 RCTs, over 2,000 shoulders. And exercise looks fantastic. Pain reduced, range of motion increased, strength increased, and functional outcomes were great. On the flip side, 15% of the patients transitioned to surgery. And they made the other comment that there weren't many RCTs and it was predominantly observational studies. Off the back of that, they basically said, look, we give a grade B recommendation for exercise therapy. So good, has its role, but not brilliant. If we then look at, and Josh is going to speak a lot more about this later on, looking at exercise versus surgery and injectables, Kajal did a Cochrane review in 2019, so a systematic review of RCTs examining surgery for rotator cuff, and they made the comment that surgery was of little or no further benefit than exercise. That said, there wasn't great evidence for surgery either, so maybe not a great standard to which to compare. The end of that is to say that exercise seems to work, but it's certainly not perfect. And Powell in 2024, so he's an Australian physio, you may have all heard of him. So Jared Powell, in his paper in 2024, looking at exercise for rotator cuff related shoulder pain, made the comment that it appears to have modest effect. So we want exercise to be better. And to make anything better, you need to know how and why. Therein lies a conundrum for us. At the moment, we don't fully understand why and how exercise works in these patients. There are a few theories. One is psychological mechanisms. So Chester in 2018 looked at psychological factors in people with shoulder pain and said, look, seems to be psychological issues have an impact on recovery, and so maybe that has merit. Okay, and we'll come back to that a little bit later on. Tendon thickness. Now, I really like this one. We can talk about this later. But what Dubé did, so in their paper in 2024, they took the results of 2 RCTs and they looked at tendon thickness, and they found that after a 12-week intervention, and I want you to remember that timeline, 12 weeks, because it'll come up again over the course of my talk, and I suspect later on. So after 12 weeks of intervention, the tendon normalised, which means a reactive inflamed tendon reduced in size and a degenerative thin tendon seemed to get some volume to it. So after 12 weeks of intervention, the tendon changed thickness, which I think is of significance, and we can come back to that. And strength is another thing. We'll talk about strength a little bit later, but Powell said in his qualitative paper that people felt better when they were stronger, so maybe there's something in that. What we have established reasonably well, though, is that motor control exercises, while they seem to work, it's not for the reason that we think. So if you're looking at scapular-focused training, it seems to be effective. but it's not because the scapula actually changes its position. So Hoda showed that in his study in 2022, that it seems to work, but it's not because of the reason we think. And similarly, acromial-humeral distance. So this is the original concept of subacromial impingement. It doesn't correlate with pain. So that's not what's being changed for us to get effects with the exercise. Okay, so Park in 2020 was one of the people showing that. So in the meantime, researchers are going, well, exercise seems to have an effect. We're not really sure. In the meantime, let's work on figuring out how we can make it better. And in the process, we might figure out why it's doing its job. So they've done a whole host of things, and I'll try and get through this reasonably quickly. So progressive versus non-progressive. Norton in 2020 did a comparison between progressive resisted exercise and non-progressive non-resisted, and basically found that progressive resisted exercise was better than placebo and better than no treatment at all, whereas non-progressive non-resisted was not better than placebo or no treatment. So it looks like progressive resisted exercise is the way to go. If we're going to use load, do we use high load or low load? Research would suggest that there's no one superior, but be guided by the goals of the individual that you're looking at. I think that's really important. We'll talk about that again. But irritability, confidence and capacity, obviously elements that go into that decision making. Whether we're going to use eccentric or concentric, small RCT by Marquez Hernandez suggested that both eccentric and concentric are well tolerated, and they both give good pain relief function, functional improvement and improvements in strength. Pain versus no pain. Pain is okay. Littlewood actually said in their paper in 2018, pain helps the patient to self-monitor better. There's some other elements to it in terms of tendinopathies that we sort of all know about, but exercising with some level of pain is fine, but be mindful of the patient that's in front of you. If they're catastrophizing, if they've got kinesiophobia and that type of thing, then pain needs to be an element that you may be a little bit more sensitive to. Motor control exercises, as I said, it seems to be effective, but in a systematic review by Zhang in 2025, they suggested that resistance exercises are actually superior to motor control exercises and scapular-focused training. Supervised versus non-supervised or home-based training. This is important because supervised training is superior to no training, but not superior to structured home-based. So clinical oversight's important, but they don't have to be supervised. These people take time to recover. And so to know that they're going to be okay in a home-based program is actually really good information for us. We don't have to have them in the clinic with us every single day. They can be given progressions and they can be sent home, and actually that's a really good thing in giving them control and putting them, giving them what we'll talk about in a moment, in self-efficacy in managing and navigating their way through this. And manual therapy, while I poo-pooed it a little bit at the beginning, and this is to do with subacromial shoulder pain, but Peters in their paper said that it's okay as an adjunct. So it can help for pain modulation, confidence and engagement. It is not the primary active ingredient though. So as long as you're using it for the right reason, it's okay. So in summary, exercise, it definitely has a role. It is getting better. We've got some focus there, and it is going to continue to improve whilst ever there's research being done. So let's talk about education. And I'm going to lean on a study by Dubé in 2023, where they did an RCT. They had 123 patients. They had a 12-week intervention, and they broke it up into three groups. They had an education alone, education with motor control, and education with strengthening exercises. And what do you think Natalia, what do you think the results were? Just keep you on your toes. All groups improved symptoms and function, but there was no difference between the three groups. So this suggests that education is potentially a standalone intervention. This tells us that education is crucial with these people. Okay? So education was comprehensive though. So I want to go through what they did in there. So they had 2 full sessions with a physiotherapist. They had 6 videos, and in that they went through shoulder anatomy and function, basic pain science, advice on pain management. activity modification, and the benefits of general healthy wellbeing, sleep, diet, and activity. This tells us that education is an active ingredient, not an optional add-on. You have to get this right. Okay, so the other things under this education umbrella, we need to think about pain self-efficacy. So how good are these people at confident are they in managing their pain, and what's their expectations of what you can do for them? So a paper by Dubé. So these guys, for this paper, they coincidentally had 123 patients as well. They really made the most of that group of patients that they got. So published in 2024, and they found that if you had better pain self-efficacy, if you had higher expectations of what the physio in front of you could do for you, you're going to get better results. Not surprising, but certainly something for us to be mindful of. Kinesiophobia, catastrophizing, other things that we can be mindful of, and the language we use. So it's funny to talk about Josh while this is his paper, but certainly the labelling. So if you haven't seen that, so this is 2021, Josh. Yep. You wouldn't remember 150. Anyway, this was in 2021, Josh. And so this was a publication just saying labels make a difference in people's decision making. So if you're telling them that, oh my God, it's torn, it's an absolute mess, chances are they're going to go, well, it's never going to get better, so I'm going to go and have to have surgery. Don't do that. Be positive, be constructive, and you're going to get better results. So rehabilitation. So we're talking about exercise and education should be framed as restoring capacity and confidence, not simply changing tendon structure. Okay, so with all that information, and this is what you really want to know, what does that do for us in the clinic? What does it look like? So it should be patient-centred, shared decision-making in a strong therapeutic relationship. It seems from the Powell paper, the context in which your treatment is given is really crucial to the ultimate outcome. Education, not negotiable, have to do it. Your language, if there has been a diagnosis of a tear, you need to de-threaten that, and we can talk about that later on in the panel about how you might go about that. I think this is important. What are potential aggravating factors and precipitating activities, and how do you modify it? So this is in keeping with what Dubé said in terms of activity modification. There is every chance that this person's pathology, if you can explain to them that your shoulder has not changed, this hasn't happened overnight. Your shoulder has become sore recently, not because all of a sudden you've had this pathology. The pathology's been there for a while. There is something that you have done. Oh, my swimming coach has recently changed my stroke. Oh, I have just helped my son build a retaining wall in his backyard. Oh, right. Okay. So if you let them understand that, they then realise, okay, so there's a precipitating activity that's brought it about. I know I can eliminate that, and I can start to move forward with getting on top of my problems. Okay. And patience is the other thing. We've talked about 12 weeks a few times now. Going to talk about it again in a moment. But they have to understand this is not going to happen overnight. Okay, you cannot say to them, I'm going to fix up your scapular position and you're going to walk out of here pain-free. It doesn't work that way. Okay, so psychological screening, so you can do pain self-efficacy, catastrophizing, it's a hard word. You can use these, they are very useful. But at the end of the day, you have to increase the capacity of this shoulder. So exercise is important. A paper by LaFrance in 2024, they looked at frequency, intensity, type and time of exercises to find out what was important of those. And they ended up saying it doesn't look like any of them are the most important thing. The most important thing is tailoring, that you tailor what you give for the individual in front of you. We've already told you progressive is the way to go. Resistance seems to be good. Pain's okay as long as it settles quickly. And home-based is good. Exercise consideration. So we need it to be progressive, and you can start minimally, so you should start minimally provoking. So you don't want to jump into too much pain to start with, and guide this by your examination. So look at position. So are you going to have them with the arm by their side, which can put more compressive load on the cuff. So maybe we lie them down, take that out, and we take gravity out of the equation. So lie them down first, just as an example, but thinking about position, thinking about movement, push, pull, rotation, what have you. Whilst the diagnostic tests the tests that Ewan spoke about are diagnostically potentially not brilliant, you can actually use them when you're designing your exercises. If you're really sore at doing your speeds, We're not going to work on that initially, but I'm going to come back to that. We're going to actually start working on that particular test. If you saw more saw an empty can, we'll work on that, but we'll come back to that. So use those as a guide. And I've got to talk about this because this is my PhD. It's 2010. And so one of my PhD was on EMG around the shoulder. So we did 1,000 different things and we looked at muscle activity. And one of the things that we found was when you flex your arm, your posterior cuff works preferentially. And when you extend your arm, your anterior cuff works preferentially, but not nearly to the same extent as during external rotation and internal rotation. So if you say, I think that pushing on external rotation is really unhappy, but I don't want to start there. What I'm going to do is I'm going to start with flexion because I know that's less. So I'm asking less of the posterior cuff when I do that. So you might start there as a way to start to work toward external rotation. I hope that makes sense. Contraction type, so you might lean on knowledge in other areas around tendons. You might start with isometric, which may actually be analgesic. Look at range. You might start small range to begin. The weight needs to be, if you're going to be progressive, you need to know what the weight is that you're using. If you are going to use TheraBand, you need to know you are standing this far away from the attachment point and you are holding it with this much tension on it, but far better to use other things potentially. Manage exposure and pain frequency. So Blycott in their paper in 2017, which talking exactly about the group, this group that we're talking about tonight, spoke about motor control. So get the motor control working. So that might even be doing the exercise a couple of times a day. Work on endurance, which might be, I'm going to get you to do it once a day, but I want you to work to fatigue. And then strength, which might mean that you're doing it every second day. So later down the track, we want you to get some grunt. So we're going to reduce the frequency, but up the ante in the resistance you're going to use. Powell in his paper has said, experiment. You'll find your way to what this person needs by experimenting. If your go-to is to give external rotation to everybody who comes in with rotator cuff shoulder pain in a middle-aged person, you are going to hurt more people than you fix. Okay, so you have to go to what you, and I'm sure you guys don't. In fact, most of the people who do that are probably at home tonight watching the footy. But I'll say it anyway. But just what I'd say to you is if you are a physio, just want some other ideas, can I suggest that you get the paper that Andrew, myself and Caitlin, who's here tonight, who's critiquing my presentation, the paper that we wrote for sports physio, just on a different way of thinking about how you might go about rehabbing these people and the different ways of progressing it. Okay, you need to measure your response. Once you've done, you're into this rehab and you need to measure the response. And so looking at function and pain is one thing. But I would highly recommend that you do dynamometry. If you don't do dynamometry, you are simply guessing. And it's not from just me, Desmils, however you pronounce the guy's name. So this is a publication from last year. They gave a grade A recommendation for the use of dynamometry when you are looking after people with rotator cuff tendinopathy. So it's not just me, it's other people as well. It's an index of low tolerance, not strength. So a paper that was published this year by Cook, Jeremy Lewis and Gerald Powell, they're at pains to say it is not, strength is not the thing, it's low tolerance that you're interested in. And is that improving as you go? You only have to go to P1, you don't have to find out what their maximum is. You get them to push to where they start to feel the pain and you're monitoring that. It gives you a starting point. So if they are pushing 50% less than their other side, this is a really unhappy shoulder and you've got to go nice and gently. But if they're pushing 75, then you know they're going to be a little bit more robust. So obviously it measures their exercise tolerance, but there's normative data on this. So if you want to go and find out what a person, so a young athletic person or, pushes for external and internal rotation here or up here or flexion extension, there's normative data out there. But the better thing to do is use their other side as a comparison. That'll give you a good idea of what's normal for them. But then you can use your optional add-ons on top of all of that. Okay, so I'm almost there. What's a reasonable time frame? So you might be saying now, I don't want to hold on to this person too long. I want to be responsible and I want to forward them on when that time's appropriate. 12 weeks, there it is again, is a defense. If you look at the research, that is a defensible time frame for you to hold on to them, give or take. That is, if they're continuing to demonstrate positive change, then you keep going. And that 12 weeks, if at 12 weeks they're getting better and better and better, then you just keep going. Monitor their function load tolerance. So that's where the dyno helps you. They can come in and say, it's still painful, and you test them and you go, mate, you're 2 kilos better. Okay, this is good. Let's keep moving on. You're going to get to a point where your cuff is better and it's not symptomatic anymore, but we're not quite there yet. Just give me some time. So think about their age, their functional demands, their patient, the preference. So they may go, look, I'm a couch potato. So as long as I can lift my beer, then I'm good to go. But you might have people, and you will have people who come in and say, look, I'm a masters swimmer. I want this shoulder to be rock solid. And so that's where you have to consider, what that time frame is and whether you're going to hold on to it or not. So no or adverse change, you have to refer. We've got some fantastic sports docs and some fantastic orthopaedic surgeons in Newcastle who will, if they don't need to have surgery or do anything, we'll send them back to you and say, just persevere. Don't need to do surgery here. I've reassured the patient, they're in good hands. But for you to have that reference and for you to have that shared decision making, it's really good. What I will say to you is the majority of these won't and shouldn't go to surgery. And physiotherapists we are really well equipped to look after these people. Okay, so we understand anatomy, we understand pathology, we understand psychosocial elements to pain. We are very good at this. Okay, so you should feel strong. I'm sure you older patients, you older physios feel confident with these people, but as younger physios, you should feel confident with these people. And after tonight, you'll be even more confident. Okay, in summary, evidence exists that education and exercise rehab are good first-line treatment. It's low cost, it's safe, and you can, give it 12 weeks and you're okay in that time frame. Make sure it's shared decision-making, patient-centred, education, obviously, tailored, progressive, and get your outcome measures. But, of course, some don't respond, so refer on to your specialist or your surgical opinion. All good?
Yeah.
Thank you.
Alrighty, we'll get straight into it. My job is going to be a lot easier than Craig's because I've got a lot less research to cover. So I'll be looking at the comparison between surgery and non-surgical management for rotator cuff related pain, and then also looking at how to apply this in shared decision making. So we've developed a tool that helps communicate the evidence on benefits of surgery to patients to engage them in shared decision making. And then I'll go over the clinical course of shoulder pain and some prognostic factors. So when looking, arrows are a bit wonky. When looking at the evidence for surgery, there's two main categories where it's been done. So one surgery is looking at subacromial decompression for impingement syndrome without full thickness tears. And then the other evidence base is looking at rotator cuff repair for full thickness rotator cuff tears. Now, we all know what subacromial decompression is, so it's a procedure to try and increase the space under the acromion. You can either shave back some bone, remove the bursa, or trim some ligament. And the research for this surgery has been compared to placebo surgery. So basically, in a placebo procedure, patients are put under anaesthetic, surgeon inserts the camera, sews them back up, wakes the patient up, so they're blinded to whether they actually receive surgery or not. And we have high certainty evidence from 2 RCTs that the decompression procedure is not superior to placebo. So it doesn't improve pain any more than having a placebo surgery, and doesn't improve function anymore. And so for this reason, guidelines typically recommend against this procedure. And like Craig covered, when we compare this to non-surgical management, so when you look at surgery versus non-surgical management, which involves exercise with or without corticosteroid injection, there seems to be a very small benefit in favour of surgery for pain, but not a benefit for function. So I like having the numbers on here. So what I'm presenting here is the mean difference in these estimates and the confidence intervals. Basically, the confidence intervals in all these cases cross the no effect line, which means it's not statistically significant. So I think what you can conclude from that is that surgery is not superior to non-surgical management. For rotator cuff repairs, the evidence base is a bit more thin, so there's no placebo-controlled surgical trials. There's one underway but hasn't been published yet. But there are 3 trials that have compared surgery to non-surgical management. Again, this involves exercise with or without corticosteroid injection. Here, the evidence is a bit more in favour of surgery, but not a huge amount. So for pain, surgery leads to around a 1-point improvement in pain on a 0 to 10 scale over non-surgical management, and about a 6-point improvement in function on a 0 to 100 scale. Key gaps in understanding the effectiveness of rotator cuff repair surgery is that we're talking here about the atraumatic full thickness tears. There's a lot less certainty in the evidence for traumatic tears in young people, and full thickness tears of the subscapularis. The other thing that is important to consider is the effect sizes here. So they're sitting at around 1 or slightly less than 1 out of 10 on a 0 to 10 scale. And so we want to consider whether this is clinically important. Now, when thinking about clinical importance, everyone probably would have heard of the minimally clinically important difference, or the MCID. Basically, this is a statistical measure when looking at an outcome that says what change in this outcome would we consider meaningful. The problem with the measure, the MCID, is that it doesn't differentiate what 2 treatments you're comparing. So if we randomize people to a trial where they do flexion exercises versus abduction exercises, the MCID is the same if we use that outcome and we compared surgery to non-surgical management. But the decision to undergo surgery is a lot more significant. It has a lot more implications than the decision to move your arm from here to here. So in thinking about that, we've done a study utilising a method called the smallest worthwhile effect. And basically what this does is it generates a measure of clinical importance specific to the decision that patients need to make. And in this case, we gave patients a scenario of this is what rotator cuff repair surgery is going to involve. This is what it's going to cost, time off work, rehab following, and this is what non-surgical care is going to look like. And so based on this, we asked patients to choose what percentage improvement would you want to make undergoing this procedure worthwhile. And so what we found was they wanted about a 40% better improvement in pain and function compared to doing non-surgical management. And then if we convert this on a scale of 0 to 100, this equates to around 28 points on a 0 to 100 scale, which is significantly larger than what we saw in that Cochrane review, where it was about 10 points out of 100. So for this reason, we can conclude that whether you do subacromial decompression or rotator cuff repair, on average, the benefits are very small to negligible. But then this raises, I guess, the other important aspect with shared decision-making is that when patients are considering surgery, they've often tried all the other options. And so I guess it's not just enough to say surgery doesn't work, you can't consider it. If they've tried everything else and they're willing to accept, a very small potential benefit on average of surgery, then I think that's up to them. So what we've done here is we've developed a decision-making tool for people with rotator cuff-related pain considering surgery. And this will be available after, so I won't go through it in too much detail. It's 3 pages. It was co-designed with patients and health professionals. And what it does is it outlines the options. So it outlines what the non-surgical options include, which is either wait and see, medications, seeing a physio for strength exercises, or seeing a doctor for an injection. Or the other option is to have surgery followed by rehab. So it outlines the options, summarises the evidence from those Cochrane reviews that I mentioned before to say that the benefits of surgery are probably less than 1 point out of 10, but also acknowledging to patients that these are averages. Some people with surgery will experience greater benefits than 1 out of 10, and some will experience less than that. So it's really just trying to give patients evidence of benefits and also adverse events with surgery, and then getting them to make a decision as to whether they think surgery would be suitable. And so here is just a depiction of complications after surgery. Yellow's minor, red's serious, And you can see that the risk of complications is low regardless with surgery anyway. So that's something else for the patient to consider. Next part is prognosis and factors predicting outcomes following surgery and non-surgical management. Now, I have a pointer. Yeah, okay. So for these, I'm going to go over what you expect to see with patients recovering from when they develop pain. This is data from a systematic review of 19 trials and observational studies. And what it shows is improvements in function and pain over time. So what you can see on the left is if the average improvement in pain and function if you do no treatment, and on the right is for people who receive usual care. I guess what you could see from here is that there's not much improvement in the first 12 weeks for people who truly do nothing. But I guess the caveat here is that there's very few studies where patients actually receive nothing. So the left figure is based on a little bit less data, so it probably needs to be taken with a grain of salt. But on the right, what you can see is that if patients are treated with usual care, whatever that may be, we can see that most experience a substantial improvement in symptoms within the first 6 to 8 weeks after their condition, and gradually can continue improving in pain and function over time. Another way of depicting this is looking at pain scores from the onset of symptoms to over time. And what you can see is that the black line is the average pain levels in a cohort over time. Again, large improvements in the first 4 to 6 weeks from symptom onset, and then there's a slower trajectory to recovery. The shaded area just shows that there's, I guess, variation in where people's baseline and pain becomes. And the black dots just show that there's variations as well. Some people have very marked quick recoveries, and other people develop persistent symptoms and tend to stay at a very high pain level. Another way of looking at the data is to look at how many people, I guess, have recovered by 1 year based on their own self-rating of recovery. So this prospective cohort study of over 2,000 people found that around 65 to 70% of people would say they've acceptably recovered after 1 year. And the results were quite similar for those who had surgery and those who were managed non-operatively. And so I guess the takeaway when looking at this data is that around 30% of people will develop persistent pain or have pain at 1 year follow-up. So I think that's something to consider when communicating prognosis, and then potentially, I guess, for researchers to try and find better treatments for those people who may develop persistent symptoms. This data is also interesting. So I guess previously or traditionally people thought that if you have a full thickness tear, you need surgery and that your symptoms aren't going to recover if the tendon's not attached anymore. This review kind of says the opposite. If we look on the left figure shows changes in improvements in function for people with full thickness tears who had surgery. And this, I guess, is as you'd expect. So you have surgery, you repair the torn tendon, you get better. That's all good. But we see a very similar trajectory for people who don't have surgery. So this is despite having a full thickness tear, they can still experience significant improvements in pain and function over time. And I guess this is consistent with the Cochrane review before, saying full thickness tears do just as well if you have surgery or you have non-surgical management. Final 2 slides, factors predicting outcomes. This is probably areas where we need better quality research, so maybe take some of this with a grain of salt. But after rotator cuff repair, the things that would indicate that someone is going to experience a large improvement in objective measures such as range of motion or strength. It's probably no surprises if they're younger and they have smaller tears, they're going to do better with surgery. And for self-reported measures like pain and function, people who have shorter symptom duration, absence of workers' comp claim, and lower pre-op function and higher pre-op pain, they experience the greatest jump in symptoms. So I don't think it's anything too surprising there. For physiotherapy, kind of a similar finding, but there's a bit less data on this. So one prospective cohort study of 1,000 people looked at what factors at baseline predict having low disability levels at 6 months. And so what they found is no real surprise that if you start with low disability and start with low pain, you're probably going to end up having lower disability at 6 months. But I think the most interesting finding here, and it's very consistent across MSK research, is that people who had high recovery expectations at baseline were more likely, significantly more likely to recover at follow-up. So I think that's also something to consider when managing patients, to try and, I guess, use language and positive framing to try and get them to have a more positive outlook on how their condition's going to recover. And also higher pain self-efficacy was another factor that predicted having lower disability at follow-up. So in summary, surgical options provide at best clinically unimportant benefits over non-surgical management options on average. And many people recover over time regardless of what treatment they receive and regardless of if they have full thickness tear. And I think the main one for prognostic research is probably that we need a bit more data on it. But I think the overall message is that most people will recover. That's all.
Evening, everyone. Sorry, my last talk. I'll try and make it as brief as possible. Thank you, Nikki and RIPN, for inviting me to chat to everyone here today. It's very sobering to talk about something that I do that apparently doesn't work at all. So, I think on the pre-night surveys, I think the things that we're trying to pick out was what are the indications for a surgical referral, the factors that influence whether I take someone to surgery or not, and what happens if we wait too long. I hope we can get through those. And start off with, I want to talk about which tears actually matter. We know that if you scan all these people in their 50s, 36% of the people with completely normal feeling shoulders, asymptomatic shoulders, are going to have a tear. So when we've got somebody in front of us between 45 and 60 that comes in with a sore shoulder and a tear, if you were to scan their other side, you'd probably see the same tear. So there might be something else that's causing them to have pain, whether it be calcific deposits or frozen shoulders setting in. So it's hard to know. And then most of the tears that are asymptomatic then proceed to become symptomatic over a period of about 1 to 3 years, even without any further trauma. But also what's nice to hear is that up to 10% of patients will actually heal their partial thickness tears. So this is the sort of gamut of tears that you can have, something from small to then involving an entire single tendon, involving more than one tendon, and then retracting and then going on to massive atrophy. So regarding surgery, you're probably not going to operate on the smallest tears. You're probably not going to operate on the massive tears with atrophy or the retracted ones because they're going to have a different salvage option. But we're trying to look at these large tears that haven't retracted too far. Then the big question is which patients matter. So there's a Finnish study that looked at 200 patients and they followed them for 2 years, and it showed if you did surgery or didn't do surgery, they all had similar outcomes, which is what we've seen for the panel today. But then there's also this Moon Group study that looked at 2,000 people and followed them for 10 years. And they found that, yes, 70% of them can be managed successfully over a 10-year period. You don't really want 30% of those people being miserable for 10 years. So how do we pick those people out early? And so I figured if people are engaged in a high-quality physical therapy program, what should trigger the referral? Basically, looks like, so that's 3 to 6 months. Full thickness tears with significant impairment, or as I think Craig touched on, if you're actually going backwards with some of your objective measures, progressive weakness and decreased range of motion. People with partial thickness high-grade tears, you can string out for a little bit longer, 6 months or so. But if they're not having any improvement in their functional scores or if they're really getting night pain, that's probably when most patients are miserable enough they want to try something else. So who gets surgery? There's a couple of biological factors that we can look at. One is the size of the tendons, whether it's small through to medium, massive. The thickness of the tear, full thickness or partial. And then even a high-grade partial that involves more than 50% is basically acting like a full thickness tear. So that's something to watch out for. The number of tendons involved, how far that's retracted, and how fatty it's become. So this is just an MRI slice that shows section A, basically, I'm trying to get my pointer up actually. There we go, so that's the supraspinatus tendon end. And it's pretty close to the footprint, it's only retracted about 10 mils or so. That's a grade 1, and then a grade 2 is when you're at the convexity of the humeral head, and that's the tendon edge there. That may still come back to where it belongs. Then there's grade 3 or pate 3, which is where your tendon edges are attracted to your glenoid face. That's no hope in hell of coming back to the GT. But it looks like someone's tried based on these anchors. Lastly, I think Joe also touched on this. Basically, we've got the fatty infiltration scale. So as the tendon's not getting activated, it's going to go on to get replaced by fat. Grade 0 is basically normal muscle. Grade 1 has a little bit of fatty streaks. Grade 2, still more muscle than fat. But at grade 3 is about 50-50. In grade 4, there's more fat than muscle. So this bottom line here, they're going to have a pretty poor outcome. They're not repairable. There's patient factors. One is duration of symptoms. A few studies have shown that if you have symptoms for less than 3 years, you're probably going to have a more successful operation or a successful outcome from an operation. Lack of cuff arthropathy. So the minute you start to get joint destruction, the horse is bolted. There's no point doing a cuff repair. BMI under 30, which is sometimes wishful thinking. An ASA score less than 3, and less than 3 tendons involved. And there's some things that are negative predictive factors. So non-modifiable risk factors are age. As you get older every decade, your chance of failure after rotator cuff repair increases dramatically. A critical shoulder angle of greater than 38 degrees increases your odds of failure by more than 14 times. And basically, that's just a line subtended from the glenoid face and then out to the tip of the acromion. The idea being the lower that acromion is, or the higher your angle is, the more mechanical abradement it's going to have on the supraspinatus. Then there's modifiable stuff that we can actually target. Bone mineral density. So if you've got osteopenia or osteoporosis, the risk of you having a failure of your repair is significantly higher. Hyperlipidemia. And so even if you control someone's cholesterol with statins or lifestyle factors, they found that statins themselves with normal cholesterol levels are still 6.5 times as likely to fail. And that might be something that's related to the actual medication. Diabetes obviously have worse outcomes than non-diabetic patients. And then if you are a diabetic, as long as you can keep your HbA1c under 7%, then it sort of starts to normalize again. And lastly, smoking. And these are the two good systematic reviews that I've sort of synthesized together to make those summaries. So who and when to refer? Given that our talk is about the atraumatic portion, the lower half of this scale. So full thickness tendon tears, significant impairment, and they failed 3 months of their 12 weeks of rehab. Probably need to see them more within the 3 month window. And if you've got a high grade partial tear with persistent weakness and you failed 3 to 6 months, then we try and catch those within the year, ideally. When referring, this is the sort of key things that we're looking out for is just the duration of symptoms and the treatment tried, and how long they've been engaged in a structured physiotherapy program, whether that be home exercise or education or whatnot. But if they've really gone through it, like every now and then you get patients who come by and say, yeah, I tried physio, and they've done two quick lessons or something. Treatment tried from pain relief. So if they're just using simple analgesia or they're using opioids, how they use a specific COX-2 inhibitor for their anti-inflammatories. And then steroids, how many, how often, what sort of effect they've had. What their comorbidities are, because that's going to change how likely they're going to get surgery. And then the functional limitations and their occupational demands. It's nice to know how affected somebody is with their range of motion, and I think that gets lost a little bit these days. We just get referrals that have people's imaging findings on there, do the necessary. But like I mentioned, MRIs are probably the bang for buck in terms of us deciding what we're going to do operatively. And then lastly, the consequence of delay. Obviously, small tears become big tears and big tears become symptomatic. This is an interesting systematic review that basically looked at all the different definitions that get thrown around. So depending on what you set your threshold for tear progression is, you can say that they don't progress at all or they progress rapidly. But when you sort of tease out, I think there's 180 studies in this, where the actual definitions were, it actually shows that most of these the box plot shows that most of the tears only grow by a small amount of about 2 millimeters, and most of the time they're getting bigger in their A to P size, so they're going backwards towards the infraspinatus rather than retracting towards the glenoid. And lastly, this is just again the fatty degeneration happens when you don't use your muscle. So 1 and 2, you hopefully would be able to get a repair on that you can trust, but 3 and 4 is unlikely to hold a suture or meaningfully move the humeral head again. And then if you missed it all, then this is what sort of happens. You lose that depressor effect of the cuff. You can start to get a high riding humeral head. Starts wearing up against your acromion. You get cuff arthropathy. And at that point, you're basically looking at some sort of arthroplasty option. Now, in terms of rehab, I think patients don't sort of realize what actually happens after an operation. They don't just get fixed and walk out. You get a sling for somewhere between 6 to 8 weeks. You're not driving for that period of time, and that can really affect some people's ability to get around, do the shopping, get to work. You're under, fairly intense physiotherapy for about 12 weeks. You're under usually some therapist guidelines going through phase 1 and phase 2 of your recovery process. And it takes about 3 months to get you back to your activities of daily living with some sort of normalcy, quality of life. 6 months to get back to activities of leisure like golf and gardening. 9 to 12 for any of the heavy activities that labourers might want to do. Which then begs the question, this might be the first time that any patient has had 12 weeks of structured physiotherapy, but they just had an operation, so they're sort of invested into it. So if you just went straight to the proper 12 weeks and convinced them that's what they needed to do, you might have a similar outcome. So in summary, who to refer, it's sort of rule of less than 3, I suppose, less than 3 years of symptoms, Catalia grade of less than 3, BMI under 30, an ASA of less than 3, and less than 3 tendons involvement. When does surgery work? I think if you can optimize all of your modifiable risk factors, you've got a full thickness tear that's small enough to bring back with no fatty infiltration and minimal retraction. And you've got a well-motivated and a patient's got realistic expectations. And if you leave it alone for too long, tears get bigger, tears get fattier, tears destroy a joint.